Hello, everyone. I would like to welcome you all today to this review of the PHP Pepper, the Pepper for Partial Hospitalization Programs. My name is Annie Barnaby, and I work for Rely Group, Inc. Rely is contracted with the Centers for Medicare and Medicaid Services, or CMS, to develop, produce, and disseminate the peppers. For those of you who might be interested in live captioning of today's session, you can access that captioning by clicking on the link that is in the QA panel. It's the very first question listed. That's where you'll find that link. Today I'm going to be focusing our discussion on the most recent release of the Pepper for Partial Hospitalization Programs, which is version Q4 CY19, CY or calendar year 2019. In this release, we don't have any revisions to the target areas. There have been no target areas that have been retired and no new target areas. So we're going to have mainly a high-level review of the Pepper, and then we'll also talk about the other resources that would be available to you. If you are familiar with Pepper and the Pepper program, there might not be a lot of new information covered today, but if this is your first experience with Pepper, I think that we're going to all find that it's a nice orientation to the program. If after today's session you still have questions about Pepper, or if you're new to Pepper and you feel that you need any additional training resources, I would encourage you to access the recorded training sessions that we have available on the PHP training and resources page at pepper.cbrpepper.org. These have been put together in shorter segments that allow you to pick and choose the information that you're most interested in. So feel free to access those recorded training sessions, again, on our Pepper website. Let's start at the very beginning. What is Pepper? Pepper is an acronym that stands for Program for Evaluating Payment Patterns Electronic Report. And essentially, the Pepper is a comparative data report, again, summarizing those claims, focusing on areas that have been identified as higher risk for improper Medicare payment, primarily in terms of whether the claim was correctly coded and billed and whether the treatment provided to the patient was necessary and in accordance with Medicare payment policy. In the Pepper world, we call those target areas. The Pepper summarizes your Medicare claims data statistics, and then it compares them with aggregate Medicare data for other providers in the nation in your administrative Medicare contractor or MAC jurisdiction, and then also in your state. And these comparisons are the first step in identifying where you might be at a higher risk for improper Medicare payments, which really simply means that your billing practices look different from the majority of other providers in that comparison group. I do want to stress that the Pepper cannot identify improper payments, but it can give you a heads up if your statistics look unusual. Looking at the history of the Pepper, we can see that the Pepper was originally developed in 2003, so it has been around for a number of years. TMF Health Quality Institute developed the Pepper, and it was originally for short-term acute care hospitals, and then a couple of years later for long-term acute care hospitals. TMF began distributing the Peppers to all providers in the nation in 2010, and then along the way it developed Peppers for other types. As you can see, the Partial Hospitalization Program Pepper has been available since 2012. Now, beginning in 2018, CMS combined the Comparative Billing Report, or CBR, and the Pepper programs into one contract. For those of you who haven't heard of the Comparative Billing Report program, CBRs summarize Medicare Part B claims data for areas that have been identified as prone to improper payments in the Medicare Part B areas. So now both of those programs have been combined into one contract. The Rely Group and its partners, TMF and CGS, began producing CBRs and Peppers. So now we are focusing on preparing the reports for that wide range of providers. Why are providers receiving Peppers? Well, CMS is mandated by law to protect the Medicare Trust Fund from fraud, waste, and abuse. And CMS employs a number of strategies to meet this goal, such as provider education and early detection through medical review, which might be completed by the Medicare administrative contractors, the recovery auditors, or other contracting groups. Also, CMS looks at data analysis. The provision of PEPR to providers supports these strategies. And the PEPR is considered to be an educational tool that can help providers identify where they could be at a higher risk for improper Medicare payments, so that those providers can then be proactive and monitor and take any measures that they find necessary. I'd also like to mention that the OIG, the Office of Inspector General, encourages providers to have a compliance program in place to help protect their operations from fraud and abuse. An important piece of a compliance program is conducting regular audits to ensure that charges for Medicare services are correctly documented and billed, and that those services are reasonable and necessary. The PEPR supports that auditing and monitoring component of the internal compliance program. Let's move on now and focus specifically on the PHP PEPR. The version Q4CY19 summarizes statistics for 3 calendar years 2017, 2018, and 2019. Now, for those of you who are familiar with PEPR, you know that each time our team produces a PEPR, we refresh the statistics for all the target areas and for all of the time periods in the PEPR. What that means is if you're looking at the newest PEPR and comparing it to last year's release, you could see some slight changes in the numerator and denominator counts, perhaps in some of the 80th percentile numbers for the comparison groups and so on. And that would be due to the reflection of those refreshed statistics, which may include revised claims that were submitted over the last 12 months, late claims, claim adjustments, those types of things. So just keep that in mind when you're looking at your PEPR. And of course, remember that the oldest calendar year rolls off as the new one is added on. I do want to talk now a little bit about episodes of care, because the PHP summarizes statistics based on episodes of care that are identified for each of the PHPs. Essentially, an episode of care represents an episode of treatment for an individual beneficiary. We do know that a beneficiary could receive PHP services for a varying length of time, which could be from 1 day to several months. So this episode is created for the entire course of treatment. To identify these episodes, we obtain all of the claims that have been submitted by a provider for a beneficiary, and we sort them from the earliest claim from date to the latest. And there cannot be any gap or break in service of more than 7 days between one claim and the next. If there is a gap between one claim's through date and the next claim's date that is 8 days or more, then we consider that to be a break in service, and so the first episode would be ending and then a new episode begins. We do summarize all of the statistics in that episode in the time period, which would be the calendar year in which it ends. That is the through date. So whenever that through date falls, that's the calendar year in which that episode's statistics are going to be reported. We do look at the claims for 1 year prior to each time period so that we can evaluate those longer episodes of care. I've included an example here to give you a better understanding of how we create these episodes. This is an example of claims that have been submitted from one partial hospitalization program for one beneficiary, just to show you the episode creation process. You can see that in the first column, these are all for the same beneficiary, beneficiary A. And we've numbered these claims submitted by the PHP in the second column, so you can see that this PHP submitted 11 claims for this beneficiary over the span of about 10 months. The next 2 columns represent the from and the through date, followed by the gap in days between those claims. And then the next column identifies which episode it falls in. And the last column identifies the length of stay for that episode of care. So you can see here that the first 4 claims are combined to form one episode because there was not a gap of 8 or more days between any of those claims. However, there was a gap of 95 days between claims 4 and 5. So claim 5 represents the beginning of a new episode for this beneficiary. The first episode ends January 20th, 2018, and that would be counted in calendar year 2018, even though it started in calendar year 2017. The second episode of care ends August 26th, 2018, and so those statistics for the entire episode would also be counted in calendar year 2018. Let's talk now about the improper payment risks that are pertinent to partial hospitalization programs. PHPs are reimbursed on a per diem basis under the Outpatient Prospective Payment System, OPPS, for care that they provide to Medicare beneficiaries. There are 4 separate PHP ambulatory payment classification, or APC, payment rates. There are 2 for level 1 service, 3 services per day. There's 1 for community health centers, and 1 is for hospital-based PHPs. And there are 2 APCs for the level 2, which is 4 or more services per day. 1 is for CMCs and 1 is for hospital-based programs. And these target areas were developed or identified based on a review of the PHP reimbursement methodology. We also reviewed issues identified by other regulatory agencies, such as the OIG, and we also consulted with CMS subject matter experts to identify those potential vulnerable areas. We looked at national claims data to help support our assessment. We do look at these target areas, the existing target areas, on an annual basis to ensure that there are still sufficient claims that have been submitted and that would be pertinent and useful information for the partial hospitalization programs. Those of you who are familiar with PEPR may notice that we have retired some target areas over time and added new ones. And so over time, the target areas can change. For this release, though, we have not implemented any revisions. This is an OIG report that was released a number of years ago. This report reviews questionable billing by community mental health centers, and it includes 9 questionable billing characteristics. The report can be found at the link on the slide. And we do have 2 target areas in the PHP PEPR that are related to the OIG's findings in this article, or excuse me, this report. The report is focused on those PHPs that were administered through community health centers, but it would probably be applicable to all PHPs. So if you haven't had a chance to look this report over, it might be a good read, even though it is a few years dated. Now in the PEPR, we summarize these statistics for the target areas. The target areas are areas that have been identified, again, as potentially at risk. We structure these as a ratio with the numerator, including those episodes that are potentially problematic. The denominator is a larger reference group, and we report these numbers as a percent so that when you look at your PEPR, you're going to see your statistics reported as the target area percent. So let's review the current PHP PEPR target areas. There are 4 target areas that are still in the PEPR. I'll review each of them briefly here. The first one is group therapy. We all know group therapy is less costly to provide than individual therapy, so this target area is looking at the financial incentives for a PHP to provide group therapy when individual therapy might be more appropriate for the beneficiary. Here we're looking at the proportion of all of the episodes where the beneficiary received only group therapy. In other words, only if the beneficiary received any individual therapy, then their episode is not going to be included or counted in this target area. The beneficiary would have received no individual therapy during the entire episode in order to be included and counted in the numerator for this target area. The no individual psychotherapy target area similarly identifies the episodes where the beneficiary did not receive any individual psychotherapy during that episode. We've had some feedback from some of the PHPs regarding the fact that the provision of individual psychotherapy is not a Medicare requirement, and that's true. PHP is in lieu of inpatient psychiatric hospitalization. But as we've coordinated with CMS, we've learned that there is a general expectation that PHPs provide some amount of individual psychotherapy as well as a range of services during that Medicare beneficiary's course of treatment. Of course, everything being focused on what that beneficiary needs. The next target area looks at episodes that have 60 days plus of service. Again, as I mentioned, there's not a limit on the length of time that a beneficiary could receive PHP. So there is the risk that there might be services continued beyond the point where they're necessary or advantageous for the beneficiary. So the PHP PEPR is identifying here the beneficiaries who receive greater than 60 days of service. And we are counting the actual days of service in this target area, not the difference between the from and the through date. This is one of those that was identified in the OIG study that was mentioned a couple of slides ago, along with the group therapy issue. And the last target area is looking at 30-day readmissions. Reducing readmissions is, of course, a continuing focus of CMS. Readmissions can be an indication of incomplete care, premature discharge, inadequate patient discharge instructions, or patient noncompliance. So we do include this readmission measure that looks at the proportion of beneficiaries who are readmitted either to the same or to another PHP within 30 days of the last date of their episode. Now, aside from the target areas in your PEPR that you will see calculated using the numerator and the denominator definitions for each of those target areas, we also calculate percentiles. And percentiles help us identify how different our statistics look from the majority of other providers in the comparison group. We calculate percentiles by taking the target area percent for a given target area. So let's say we're looking at a group therapy and we take the target area percents for all of the PHPs in one of the comparison groups, let's say the nation. All of the PHPs in the nation, we take their target area percents and we sort them from highest to lowest. To identify the 80th percentile, which is an important point in that distribution, we identify the point below which 80% of those target area percents fall. And that point in the distribution is called the 80th percentile. Now, why is that 80th percentile important? Well, in the PEPR, we use the 80th percentile to identify what we call outliers in the PEPR. These are providers whose target area percent is either at or above the national 80th percentile. So if your target area percent is greater than that point where we've identified the 80th percentile, then in the PEPR, you're going to see your statistics identified in red bold font. That's the visual cue that your statistics look different from most of the other providers in that comparison group. And I want you to just keep the image of the ladder in mind as we walk through the sample PEPR here in just a moment, because I think it's a great visual that explains that 80th percentile. The other thing you're going to notice in your PEPR is that we have these statistics of the comparisons for three groups. The first one is national. Of course, that's all of the PHPs in the nation. And we use the national 80th percentile to identify outliers. But you will also see the MAC jurisdiction comparison group, which is comprised of all the PHPs that submit their claims to the same Medicare administrative contractor. And then we also have the state comparison group, which is the smallest. So I'm going to turn actually the presentation over to Kim Rahor at this time. She has a sample PEPR that we're going to walk through as a nice demonstration and review.
Thank you, Annie. Again, this is Kim Rahor. I'm with the RELY Group, and I'm going to go ahead and walk through a sample PEPR for partial hospitalization programs. Now, the PEPR may look a little bit different to those of you who are familiar to using the PEPR, but all of the data and the information that you're used to seeing is still included within the pepper. So we're going to walk through this real quick and show you how things have been rearranged a bit. Now, for those of you who are new to the pepper, I do want to just mention that the pepper is distributed electronically. It is a Microsoft Excel workbook, and you will navigate within the pepper by clicking on these worksheet tabs along the bottom of the screen. When you open your pepper, it's going to first show you this tab called the Purpose page. And you will notice that now we have the CMS logo included on the pepper on the very first page along with our pepper logo. On row 11, you are going to see your 6-digit CMS certification number, your CCN or provider number, along with your provider's name. On row 12, it's going to identify for you the most recent calendar year that is summarized within this release of the pepper. The next tab is the Definitions tab, and here is where you can find the complete numerator and denominator definitions for each of the target areas in the pepper. You'll also notice that throughout the pepper, we've removed any hyperlinks that we used to have to different worksheets within the pepper or to our website. The reason for the removal of the hyperlinks was to ensure that the peppers are compliant with 508 accessibility guidelines. That means folks that have hearing or seeing disabilities will be able to utilize the pepper using their specialized accessibility software. The next worksheet is called the Compare Targets Report. And as always, this report I like to refer to as the heart of the pepper. It is the only place within the pepper that you are going to see your statistics for all of the target areas all in one view. Now, it does summarize only the most recent calendar year of statistics. And so here we're looking at the statistics through the fourth quarter of calendar year 2019. You will also notice that this report looks much more compact than it has in years past. And that's because we have removed the description from the target area, I guess you can say definitions. Now we just have the target area names listed here. We still will show you the numerator count, which is the number of episodes that meet the numerator definition. The denominator definition is not included on this report. However, it will be included on the target area reports as in the past. Now, the reason this report is so helpful is because, again, it does show you everything on one worksheet, and it also helps you understand how your statistics compare to those three comparison groups that Annie mentioned just a little bit earlier. So you remember that when Annie walked through the target area definitions, there was a numerator and a denominator definition. For the group therapy target area, we have 43 episodes that meet the numerator definition. When we compare that to the denominator definition, which is not included here, we can calculate our target area percent of 37.7%. Now, most of you can probably calculate your own target area percents using your own claims data, but the value of the pepper comes in when you are able to understand how your target area percent compares to that of other PHPs in the nation, in the Medicare Administrative Contractor jurisdiction, or in the state. And so that's where these percentiles come in handy. So when we look at our target area percent of 37.7, and thinking about that ladder image that Annie just showed us a couple of slides ago, those target area percents for all of the PHPs in the nation are sorted from highest to lowest. Our target area percent of 37.7 is at the national 10.3 percentile. That means that it's pretty far down there towards the bottom end of that ladder. Only 10.3% of all the PHPs in the nation have a lower target area percent than we do. Now, if we were at or above the 80th percentile for nation, then we would see our target area percent here displayed in red, bold font as a visual cue to help that stand out to us. But for this target area, this PHP is on the low end of the scale, and so probably doesn't have much to be concerned with. Now, normally here we would see the jurisdiction percentile, but you'll see that both the jurisdiction and the state percentile cells are empty for this particular PHP. And what that signifies is that there are fewer than 11 PHPs in the jurisdiction that have sufficient data to calculate statistics for this target area. And when that occurs, we do not calculate percentiles for the jurisdiction. And then similarly, when there are fewer than 11 PHPs in the state with reportable data, we do not calculate the state percentiles. So in those instances, you'll see blank cells. This last column here shows us the total amount of Medicare reimbursement that our PHP received for these numerator episodes. So this can be really handy in helping you identify, first of all, for these target areas, how does your target area percent compare to those for the nation, the jurisdiction, and the state, and then how much Medicare reimbursement might be involved with those particular target areas. The other thing I'll point out is that you'll see here this PHP only has 3 target areas listed on this report. The 4th target area is not included, and that would be because this provider does not have sufficient data to generate statistics for calendar year 2019. So if there are not sufficient statistics or sufficient episodes for statistics generation, then we're not going to see it included on the Compare Targets report. One other thing that I'm going to point out is that this is the only place within your PEPR that you are going to see your exact percentiles. On the target area reports, you'll see how your target area percent compares to that 80th percentile, that line in the sand that Annie just covered. But here you will see your exact percentiles for calendar year 2019. All right, so let's take a look at some of the target area reports. The first thing that you're going to notice when you click on the report target area report tabs is that the graph, which used to be at the top of the report, has been moved to the bottom of the report. And again, this was made primarily so that we can be compliant, again, with those 508 accessibility guidelines. But the information that you're used to seeing, even though it's been rearranged a little bit, is still available. So for this target area, group therapy, we do see your PHP statistics for calendar year 2017, calendar year 2018, and calendar year 2019. We have added this row here for outlier status that will identify whether or not you're an outlier for this particular target area and time period. So we can see that this PHP is not an outlier for any of these target areas or time periods. Next, you're going to see your target area percent, and these are the values that are going to be graphed as the blue bars here in your target area report. That hasn't changed. Again, it's just been rearranged a little bit. the target count is the numerator, and then the denominator count, of course, those are the episodes that qualify for the denominator definition. We also include the average length of stay for the numerator episodes, as well as for the denominator episodes, the average amount of Medicare reimbursement for the numerator episodes, and then the total amount of Medicare reimbursement for those numerator episodes. And all of this information was previously included in the PEPR. Below that, as before, is the comparative data table, which identifies for us the target area percent that is at the 80th percentile for the nation and for the jurisdiction and for the state. Again, for these 3 calendar years, and these are the values that are graphed as the red lines in the graph here below. The solid red line is the national 80th percentile. The dashed red line is the jurisdiction 80th percentile. The dotted red line is the state 80th percentile. And since we were not able to calculate jurisdiction and state percentiles for these 2 target areas, you'll notice they're not displayed here. What's nice about the graph is that it just gives us a nice way to evaluate our target area statistics, whether they have changed over time, how close we are to that 80th percentile. You can see here that we're below the 80th percentile, but getting kind of close. And one thing that popped out to me was as I was looking through this sample PEPR is that there has been a fairly significant decrease in the target area percent for group therapy for this PHP. And I always encourage people to think about what factors might be leading into any significant increases or decreases that they see in their PEPR statistics. There could be changes in patient population, in referral sources. Maybe there's been staffing changes within the organization and you're now providing different types or different levels of services than you were before. There could be changes in coding or billing staff. There are a lot of different factors that play into what you're seeing in your PEPR. So if you look in your PEPR and you see increases or decreases and something doesn't quite look right to you, I would encourage you to gather some folks within your organization together to examine the numbers, perhaps pull a few medical records, compare those to the claims, and see if there is anything that you need to be concerned with or if what is reflected in your PEPR is what you expect to see. We still include these suggested interventions below the graph. The suggested interventions, which are also included in the PEPR User's Guide, are very general statements. If you were an outlier for this target area, what might you think about looking at? What could be some of the concerns involved with that outcome? So they're provided there as guidance for you, but certainly not meant to be set in stone. You know, also as you look through your PEPR, this new format, everything is going to look bigger. And so all the fonts have been enlarged. Things are going to look a little bit different, but trust me, everything is still there. So each of these target areas has a tab within your PEPR, and you're going to see the same type of information available here. This provider also had a significant decrease for the no individual psychotherapy target area. At times, if there is not sufficient data for calculation of statistics, you might find that your report is completely empty. There are no blue bars here on the graph. In the data table, it's going to tell you there was no data. That occurs, again, if there are fewer than 11 episodes that meet the numerator or the denominator definition. All right, and then lastly, we have a couple of supplemental reports within the PHP PEPR that don't have any bearing on outlier status for your organization, but they're just provided for comparison use for supplemental information. The top diagnoses tab shows you the top diagnoses, the top CCS or clinical classification software diagnosis categories for the most recent calendar year. It will show you up to 10 categories. You will notice now that we no longer have blank rows. This PHP only has sufficient data to calculate numbers for these 3 categories. We will show you the total number of episodes for each of those categories in the calendar year, the proportion of episodes for each clinical classification software category for, as compared to total episodes, and then your average length of stay for each of those categories. The Nationwide tab provides the same type of information, but it's aggregated at the national level. So it's going to include all of the PHPs in the nation. You will see the top 10 categories, along with the total number of episodes, the proportion of episodes to total, and then the national average length of stay. So some of you might find this type of comparative information helpful in your normal operations. So that is a quick review of a sample PEPR. I'm going to go ahead and turn the presentation back over to Annie, and we'll continue.
All right, that was wonderful. Thank you, Kim. So after that wonderful review of the sample PEPR, let's talk now about what the PEPR means to you. We got a lot of information, again, from Kim in the sample review, but we do often get questions from providers. Do they have to use their PEPR? Are they expected to take action or make some change based on their PEPR? We've had several questions from PHP providers as to what we expect them to change. And in reality, the providers are not expected to make any changes. There's no requirement to use your PEPR. There is no expected response for whatever your PEPR statistics show. The main thing that we want to point out is that the PEPR is really a roadmap that can help you identify when you might be at a higher risk for improper payments. It's a free report that's made available to you by CMS. Remember also that there are a lot of other federal contractors that are looking through Medicare claims data, databases, in an effort to identify providers that could benefit from perhaps educational outreach, perhaps a medical record review, or some other focused intervention. So it is helpful to know that your statistics look different from other providers and to know that just because they look different doesn't mean you're doing anything wrong. And that way, when you're looking at your PEPR data, if something doesn't look quite right in your mind, you have that opportunity to dig a little bit and see if there's something going on that might need your attention. Sorry about that. Okay, there we go. As you may know, PEPRs are distributed annually in electronic format. There are 2 distribution methods used for PEPR distribution, and the method depends on whether the PHP is a unit of a short-term acute care hospital or inpatient psychiatric facility or a freestanding community mental health center. Because PEPR does contain hospital-specific sensitive data, we cannot send it through email. Most providers are going to be receiving their PEPR through QualityNet because most of the PHPs that receive a PEPR are a unit of either a short-term acute care hospital or an IPF. QualityNet is a secure distribution system developed by CMS for the reporting of hospital quality data. The hospital's QualityNet administrator can download the PEPR, and that person is usually involved in the hospital's submission of quality data. If there isn't a QualityNet administrator at your hospital or IPF, we advise you to contact the QualityNet help desk and they can assist you. In addition to the hospital's QualityNet administrators, those that have a basic user account can also receive the PEPR. The file is available for 60 days from the date that it's uploaded into the QualityNet system. And if you for some reason haven't yet downloaded your PEPR, we would encourage you to do so because after those 60 days, the file will be moved out of the QualityNet system. But we can upload that file again. You'll just need to contact us through the help desk and make that request. The Community Health Center PHPs are going to get their PEPR through the PEPR Resources portal. You'll click on the PEPR distribution, get your PEPR link. There are some instructions there to access the portal, and each release is going to be available for approximately 2 years. So if you didn't get last year's PEPR, you're still in luck and you can still get last year's PEPR through the portal. You will need a couple of pieces of information to access your PEPR. You will need your 6-digit CMS certification number, as well as either a patient control number or a medical record number from a claim for a traditional fee-for-service Medicare beneficiary that received services during the last 3 months of 2019. Before I move on, I also want to mention that if you're trying to get your PEPR through the PEPR Resources portal, and if you're struggling to do so, the last thing that we want you to do is to be frustrated and give up. Please contact our help desk. We have a great team and they can help you access your PEPR. So don't let that frustration get the best of you. Once you get your PEPR, if you do see that you have some red numbers here and there, the first thing we want you to do is to remember, do not panic. Remember that just because you're an outlier, again, it doesn't mean that there is any compliance issues that exist. It doesn't mean that you're doing anything wrong. But let the PEPR open up a review of why you may have been an outlier. Do those statistics in your PEPR reflect what you expect to see given your operation, your patient population, your referral sources, the staff that you have on board, your healthcare environment? There are a lot of factors that can make your statistic look different from others. So just think about that. If you feel that something looks unusual, we always encourage providers to run some samples and look at the documentation in the medical record. Compare that with what was submitted on the claim. Was everything coded and billed appropriately based on the documentation within the medical record? Ultimately, you just want to make sure that you're following those best practices, even if you're not an outlier in PEPR. Every year, we do put together aggregate data on the target areas as well as the top diagnoses. These are updated on the data page at pepr.cbrpepr.org. And these have been posted and made available for the PHP, so you will find the calendar year 2019 data there now. Other resources that you will find on the website include the user's guide. There is a spreadsheet out there that identifies the total number of PHPs and each MAC jurisdiction in total and by state. And of course, those recorded PEPR training sessions that we mentioned earlier in the webinar. And a sample PEPR also if you're interested. If you find that you need further assistance, please contact us through our help desk, which is on the website. There is a form that you will submit and a member of our team will contact you promptly. Just remember to not seek information from other associations or other organizations. Our team is the official source for information on PEPR, and we want to make sure that you're getting the right answer and the guidance that you need. Here is a screenshot of our website, the homepage. You can see the partial hospitalization program, that blue arrow pointing. It's in the middle bottom part of the screen. This is where you can access the user's guide, the training and resources, as well as a link to that distribution page.